a lot.
Tell us where you're from.
Oh, I'm from Venice, Florida.
Okay.
I'm Diane, and this is my daughter Jessie. She's the patient.
Well, thanks for coming.
And I've read a lot about stem cell therapy for autoimmune disorders. I was wondering if any activity is going on for TTP in that regard. Not that they're aware of.
No. I think that is given the, so you have like a stem cell therapy is like bone marrow transplant. And broadly speaking, the therapy that you need to sort of start that is pretty intense. And so we kind of save, that's held behind when you have nothing else to do. I'm probably speaking out of turn, but like it's, for TTP, because we do have other options, other treatments, I don't think that's been explored.
Because in my mind, it would get to the root cause and stop the whole issue from happening at all, rather than trying to come up with solutions to treat it.
Yes, but what I tell my patients, remember that everything that we do in medicine, everything that we do has a risk, a cost, a consequence, right?
A cost, for sure.
There's what I call the glasses half empty, half full. And the other thing that is also, you hope that there's benefit. It helps, heals, cures, makes things better. Yes, that's the promise, the hope that like with stem cell therapy, you're knocking out the immune system and replacing it with someone else's. If it was that simple, you kind of would have been doing it by now. I mean, yes, it is done for autoimmune diseases, but in very select cases.
I actually heard for the first time this meeting from Marshall, there's some talk about something called CAR T cell therapy. So these are engineered T cells. They take yours out, engineer, and put them back in to attack whatever they can sort of engineer it to. And there's some discussion about using it in autoimmune disease.
There is a company, it's like a bunch of people from Penn, and I did some consulting for them. They were, you know, you can do this. I mean, we're doing this CAR T therapy is done for leukemias, but it's comes with a very hefty price tag.
Both financially and potentially side effects. So it has to be safe, right? The whole treatments we use for TTP can range from rituximab to cyclosporin, which are fairly benign, to more severe things, and older chemotherapies that we just don't use anymore. And I would say the stem cell options, immune therapies are sort of on that, more the unknown. The immune system is fairly powerful. It can cause and cure disease. So you have to sort of be careful what you do. And we always say it's better to not be the first person getting that therapy on the study. Let people who need it more take those chances, if you will. That's kind of that's why the sicker patients do the earlier studies, essentially. So it's possible, but I don't think it's ready for prime time.
So is there any research around excessive stress causing TTP? I've been racking my brain trying to figure out why it happened to me, I guess. So I didn't know if excessive stress was something that has been looked into.
It won't make anything better, that's for sure. I mean, that direct correlation of stuff hitting the fan, it's not the word that's in my head, developing TTP, no, I don't think there is. I mean, you know, there are people, and we say this because there's people who are doing great, right? Then all of a sudden, what the heck, I've got this headache, I'm covering these red spots, I'm bleeding. There's people who their, you know, lives are crumbling, and of course this is just another thing. No, I mean, that is the million dollar question, which, you know, that we can't answer is what's the reason that the immune system, which is designed to protect us, guard us, defend us, of all the things in the human body to attack, why the heck is it picking out of TS13?
Yeah, I don't think there is any good study that has compared stress to TTP or any other autoimmune disease, but in general we feel that stress has been linked to increased inflammation. So maybe something to do with the inflammation that goes around and flares of autoimmune diseases.
There's no question that your own stress level can affect your own emotional health, affects your immune system in many ways, but when you say stress, it's hard to know what's one person's emotional stress leads to physical stress in terms of inflammation. That's where it's hard. It's been studied for years. In medical school, I gave a tube of blood. Every week after our test in medical school, they would give you $20 if you gave them blood. So it was great pizza and beer money. So after a test, they were studying how a week of studying was affecting your immune system, I guess. Never heard it happen to it. I got $80 out of the deal, so. People have been looking at it, but it's just, it's hard to nail down. Pretty complex system.
I have a quick question. I also have like public speaking issues, so I might relapse sitting here talking to y'all from stress. But, I live basically in a state of a TTP episode with having a horrible headache I've had every day for 2 years, and it's the same headache I had on the onset of my attack. And dizzy spells, I see stars extremely often, a bruise everywhere, and I just live with this fatigue where I have 4 days a month in between my plasma exchange where I just feel good, but then I just go back to feeling like how I felt before. So I kind of live in the state of a TTP side effect, but I see on the recombinant atom 13 study that there's been 0 side effects reported. So I was wondering, has there been anything curing it as far as like the side effects people live with? Do they feel like they're feeling better, their headaches are gone, their fatigue is better from the ADAMS 13, or are they just living in a state of, I'm not getting an attack?
I have heard that side effect from a lot of my patients, and some of them actually complain of these similar symptoms when their ADAMTS13 goes down. And whenever we use like rituximab or some other immunosuppressive medication, and when the level normalizes, they tell me that their headaches have gone down. Whereas other patients have an absolutely normal ADAMTS13 level, and they still keep getting these headaches and fatigue and other minor symptoms that tend to linger for a long time after the acute episode is over. And I think sometimes I have sent them to neurology, like for treatment of migraines, and that has helped some of the patients. Some patients have had some benefit from behavioral therapy, and like just like trying to cope. Anxiety can sometimes lead to these kind of symptoms. And fatigue, I think in general, most of the symptoms, I think it's universal to have fatigue after TTP. At least majority of our patients complain it for the first 6 months to 1 year. And I think with time, it tends to get better.
Yeah, see, I have congenital, so that's all I receive.
Yeah.
So my atoms is staying low, and then
So it's
kind of that's like my issue there.
it's
It's
different.
just,
Yeah, I think we on the adult side we mostly deal with the immune kind of TTP. So I think for you it's always there, like it's always low.
We do know the immune patients do have a greater risk of headaches during the follow-up migraine attack. I think that's been studied, and it was studied our consortium just finished. It's going to get reported in December. Shows a lot of long-term effects in people who are in remission. And at a quick glance, there was no clear connection between ADAMTS13 activity and some of these symptoms. Doesn't mean there's not a relationship, but we're not seeing a clear relationship yet. Many of these side effects are probably going to be related to other things in addition to or separate from the ADAMTS13. So there are a lot of things, ADAMTS explains a lot of things in TTP, but not everything. I think there's more to learn about other things that are going on in patients.
But after people have had strokes, head injuries, a side effect of that initial event can be recurrent headaches, migraines. I'm going to assume that they've already checked you for other things, like you've not had a bleed in the brain, you've not had blood clots in the brain.
yeah, blood clots and then the silent stroke.
I'm sorry.
Silent stroke.
So you did have strokes, okay, and how about blood clots? I'm going to assume they've already checked that you don't have blood clots in the brain, that you haven't like any blood clots.
No, not currently. They said that they actually found another genetic deformity where my veins kind of in my head dispersed like a tree. So they said it shouldn't cause me any issues right now, but I never had headaches before TTP.
Right.
So.
I mean, yeah, you do see this, especially after our patients who, if they've had TTP or any other sort of, we see this more common in our patients who've had, who've had what we call venous stroke, venous thrombosis. it came, it happened, we treated it, it's gone away, but the side effect of it can sometimes will remain, and that can be headaches. And so,
I mean, congenital patients are a little bit different than immune-mediated patients. And there are headaches that happen with a normal platelet count. And, you know, Marie Scully's study looked at some of these symptoms with normal platelet counts and giving them concomitant to help those symptoms. So the best answer you might get is in the next 2 months, you should have access to recombinant ADAMTS13. And then you're going to be able to get on a regular program where you'll be able to achieve clearly higher levels than you can with plasma. We really just learned, we knew this, we now confirmed it in the studies. You just don't do a good job with plasma in terms of the ADAMTS activity. You can with the recombinant, so you'll get one of the first-hand looks and see if it helps.
Thank you.
I just had a connection. I think we talked about this a little, but I have the autoimmune, but I always have low ADAMTS13, and I have a lot of the same chronic symptoms with the headaches, the stars, the fatigue, the dizziness. I have all that too, so that's why it makes me wonder too. The same thing is, and they haven't been able to figure out if it's connected or not.
Yeah.
So just something interesting, because I do have the different kind, but because mine's always low, I don't know if it's similar, you know, if that's why I have similar symptoms to you.
Yeah.
So mine is not low, but I have the stars, and I have like a flash in my vision sometimes. I look at a computer screen all day. I'm an accountant, so so there's times when I have to kind of refocus my vision. So I mean, even with my ADAMTS13 not low, I'm having those things too. So.
yeah, but that can all just be like, right, you had the event, someone has an event, and it's just like the consequence of it.
Yeah.
I mean, I think collaborating with a neurologist, I mean, you have migraine type headaches. I mean, there's lots of treatments for that are available. I mean,
If you want to make it a little bit more complicated, I'll do it in a straightforward way, I hope. So when you do an ADAMTS13 test, we're measuring in a lab your body's ability, your plasma's ability to cleave that von Willebrand factor, right? But we don't use it full length. There's sort of a fragment that's used. So there's a small percent of patients on either end that don't correlate. So meaning you may have low ADAMTS13 activity, but you don't. You should have those multimers because they're not being cut, but you don't have those. On the other side, there are people who have closer to normal activity, but a small percent, 10 to 15%, do have those multimers. So we're trying to approximate in the body what's happening in that lab test, but it's not perfect. So that's where there always could be some variability in that. That's where you always have to be careful. The most important thing I learned in medicine over the years is there's no black and white laboratory test between falsely positive or negative results, or it's doing its best that it can to measure what's happening in the body, but it's not recreating perfectly what's happening. So these all help us, don't get me wrong, but you know, there's no absolute answer sometimes. You don't absolutely know sometimes.
I have one more question. Sorry.
You got plenty of time, you won't.
So I get plasma often, like I had said. A lot of the time recently, within the past 6-7 treatments, I come home and I get really bad hot and cold flashes a few hours afterwards. And then my muscles ache and I can barely get up, and I'm freezing, and then I'm hot and I get really, really weak. And then the headache goes full-fledged where I can't, if any light comes in the room, it's excruciating. And it's only been in the last 5 or 6 treatments. I've talked to my current hematologist who doesn't deal with TTP and hasn't before. And she's mainly hoping that you guys will tell me something today of what to do or how to avoid it.
I mean, have you seen a neurologist before?
I've seen so many doctors. I'm sure. Maybe not. I don't know. Honestly, I've lost count.
It's worse though after you get the plasma.
Yeah, it's worse after I get.
I mean, if you ask most congenital patients, they feel lousy after plasma. Just like plasma exchange, for whatever reason, you see patients in the hospital after plasma exchange, they're wiped out. It's more than just the Benadryl. It's the stress on your body from the exchanging the fluids, the electrolyte shifts. People are wiped out, and the same thing happens with congenital patients. in doing the congenital TTP study at Ohio State, it was very clear that patients felt much better. They didn't have that same problem. They went home and went about their day, as opposed to when they got plasma, they felt lousy. And that study, they had to get both of them. They were sort of randomized to one or the other to switch. So there's no question people feel a lot better after. So much of what we got might be from the plasma infusion, all the Benadryl, reactions to plasma.
Yeah, because you're getting what are called single donor units. Each of those bags is some random person who was donated. If that person was having an allergic reaction that day, that person was a little under the weather, tied one on the night before, that's all, and we hope not, right? But that's all going into you. So options until recombinant ADAMTS13 comes out is, you try to do like more aggressive pre-meds before doing plasma. If they can, there's an option, another plasma product called Octaplaz, which is a pooled plasma product. So they take, 1,600 of those plasma bags and mix it into a vat and pool everything. So if there's someone with like an evil humor in there, it's diluted out amongst hundreds of other units. And that has a lot less reactions to it. And then I guess if if someone is really having a problem with plasma, there's a plasma concentrate that's available. Do you want to talk about COE?
Yeah, there are actually a few people here.
Oh,
Yeah,
sweet.
I believe Keith,
Yeah. All right. Yeah. Well, then why don't you pop up, man? He's over here. Yeah. So there's this thing called it's a plasma derived. It has been used for hemophilia, and it has it's what we call low to intermediate purity. Not that there's like hair and band-aids and stuff like that, but it's not pure factor 8. So it has like Willebrand factor, and it's all these other things. It has factor 8, but it also has 100% ADAMTS13 in it, just because it's derived from plasma. So that's something that can be, for the people who've had allergic reactions to plasma, it's, we can't give them enough. They're going to need this every week. We have right? I'm going to assume this is just a concentrate, right?
Mm-hmm.
This is an infusion as opposed to like a drip.
Yeah,
and that can be.
I get it in vials and I mix it myself. Put it in a syringe and do it through a butterfly needle. And I do.
And you can do that at home.
I do.
We did it here Friday.
Yeah, we can.
After we showed it.
Yeah,
Well, that's the hope of the recombinant. It's not just that it's better tolerated, that it can be given at home. The hope is that it can be given subcutaneously someday. So the biggest problem with the plasma is what we think you need to deliver the ADAMTS and what you're willing to do, meaning the time commitment. Most patients probably need it weekly, but they're not going to tolerate weekly plasma infusions and feeling lousy afterward. With the recombinant, and especially if you can dose it at home, you can go on a bigger schedule, a more frequent schedule, if you don't have to drive an hour to town to get it and wait in the clinic for an hour and all that stuff.
With the factor 8, as you said earlier, with medical, there's always benefits and counter benefits. We toe that line of a high factor 8 level.
How high?
200, 198, 200. It's seldomly on the day. Yeah, it's not an extended period of time at 250. It's not putting us into that. But we're up in that 200.
Yeah, I'm gonna have to tiptoe this. It's factor 8 yes, if we get levels of 400 or 500, we're going to panic a little bit. We're gonna get upset. But in unless you have hemophilia, most of us, if you fall and break your leg, you're stressed out, something physiologically shakes you, your factor 8 level can easily go to 250. So I think part of that is just going to be a risk-benefit discussion. If I had a patient with congenital TTP who's still having symptoms, I might tolerate a higher 8 level. But it's, if it's preventing strokes, preventing relapses, that 8 is just a number at that point. In my opinion.
2 years, so.
I'm sorry?
He's been on it 2 years.
And, well, fortunately, that should come to an end soon.
And especially for patients who can't tolerate plasma, either because of the infusion long amount of time that you have to spend in the infusion center.
I think every patient can't tolerate plasma. You know, some have reactions.
Some kind of.
But what we really think we need to give people, there's no way they're going to do it. If you look at the data from the study, we cover them for a couple of days. We don't get really good extended levels of plasma. You will get that with a recombinant product because you know what you're getting and you know how to get it. So if patients really did what we thought they needed, they would hate us and they would refuse to do it because it's just a lot. You know, if I asked you to do every 5 or 6 day plasma, you might smile and say, I'll think about it, and you wouldn't even say it. It's just, so that's the, people ask us, what's the optimal schedule for congenital patients? We say it's a negotiation of what we think they need and what they're willing to do, and I get it. That should be off the table, not finally.
I have another question. You've been talking about recombinant, I don't know how to say it, recombinant atoms, 13, TS13. And I've heard talk this weekend about it, trying it for ITTP. So that's one question, is that in fact something that's being looked into? And then the second question I have is associated with that. If you put Adams TS13 into a person whose autoimmune system attacks it, is that going to make their immune system attack it more? No. Good.
It's a good question. In the congenital patients, people did not develop after a year antibodies against the drug. There was antibodies, but they were not antibodies that interfered or cleared the drug. It doesn't seem that way. Maybe it's a different story in immune TTP when people already are making one antibody. But thus far, it's not. There was one study that's been done. It was more of sort of a dose-finding study. There's now an ongoing study with recombinant atom TS13 and ITTP, similar to the Maori study, trying to minimize or eliminate the need for plasma therapy. So it's being studied right now, as is the Maori study with capitalization, minimizing, avoiding plasma exchange. It's a good question.
I was wondering trying to think of what patients can do for themselves. Or, I mean, I have a hematologist, we have a plan, I get my blood taken all the time, I monitor all that stuff, I do all that stuff. But for one thing, you talk about checking Adam TS13, maybe every 3 months or 6 months. But is there any, like, for instance, can a patient know that something's changed? Is there any symptoms of something changing in your Adam TS13 level that I can detect? Because it's like, maybe 6 months is enough, but I'm on the 6 month schedule. Like otherwise, we're just going to stay on 1 month schedule.
Unfortunately, I think most of the patients don't develop symptoms until the levels are too low and until they start seeing the low platelet count and all the other clinical manifestations. And that's why we advocate for close monitoring, because especially when the Adam TS13 itself is going down, most patients are asymptomatic.
Okay. My only symptom of having low is TTP. That's the only thing I don't get. There's no warning, right? Yeah. Okay. So the other thing is that, you said, I don't want you to get lung cancer, stop smoking, right? So I don't want you to get TTP. Is there anything that patients, there's probably no, but is there anything patients can do to, is there anything that we can do to try to avoid it, or to, it's an autoimmune disease. Like, how do we treat it as an autoimmune disease? There's got to be.
Right. So, I mentioned, right now, I think the only thing that we know of is making sure, we've moved away from just checking platelet counts to checking Adam-TS13, right? And so what is the appropriate schedule for checking Adam-TS13? The International Society of Homeostasis States, their guidelines, they didn't make any recommendations like, well, we don't have it. The USTMA we're recommending every 3 months. And I think, in the beginning, when someone comes out of the hospital, I check that Adam-TS13, probably too much, which I think is such a thing, but, weekly at first until I know it's up and stays up, and then with certain patients, you can then sort of see, you know, what they do. So if I knew there was a patient who had been up and stayed up for months, if not years, then we'd probably stretch it out. But right now, is there anything else that we can do? Right now, it's just monitoring that ADAMTS13 level, is making sure that it stays up. And if it starts to fall, you know, at what point in time do you pull the trigger for preemptive therapy? Did that answer the question?
Well, it's kind of a no change to what I do. I mean, it didn't say,
Right,
here's something else, here's something else.
You made a good point in your talk. You have to,
There. Oh, thank you.
your blind spot bumps into that once in a while, right?
Right, a broken clock is right twice a day, right? You know?
No, but you talked about the norm, watching the diet, don't gain weight, smoking, blood pressure, we know that there may be a risk for cardiovascular in the future, so those are the routine things, but you also want to do the things that he mentioned also, the mammograms, the colonoscopies, the routine stuff. You don't want to ignore the rest of this stuff, you don't want to associate everything is from TTP, so if your ADAMTS is normal, then you're good, you don't have to do that. You still should do the kind of good, clean living stuff, we'll say.
I'll throw something up there that might not be, I'm going to ask everyone else who's here to also chime in. I mean, I've seen this more in like my ITP patients. There seems to be time in my ITP patients where some sort of viral infection, something that pisses off the immune system again, and they relapse with ITP. And so I think one of the things if I had to say, like, what else could a patient with TTP do? In addition to all the preemptive, the other sort of healthcare maintenance stuff, I would recommend vaccinations. I would say getting COVID would probably be a nice flare for someone's TTP. If we're going to antagonize your immune system again, I worry orders of magnitude less about vaccinations to the point where, like, you know, I would much rather have someone vaccinated than not. I'd much rather have someone vaccinated and then we deal with it than getting COVID or flu or RSV. And then having on top of that a recrudescence of their TTP. So I'm going to ask everyone else. I guess we'll start. Can we go this way? And whether or not you agree or disagree, or like?
Yeah, definitely. I think anything. I mean, most of the autoimmune diseases pair up with viral infection. You need some kind of trigger that kind of dysregulates your immune system. So totally agree with vaccines.
I mean, I'll echo that. I'll also put a plug in for our vaccine and TMA session. During the next block, because we sort of discussed this, you know.
I planned it now.
It's a great segue.
So, yeah, thank you for that.
Just on that though, is that, because my doctor said, you just had rituximab, your COVID vaccine isn't going to work for like minimum 6 months.
Yeah.
So we're going to give you Evusheld.
Sure.
And ask them, anybody know what Evusheld? Nobody knows what that is, but that's what I got.
What?
Oh, it's not a common thing.
I had that.
What was it?
We're given.
Yeah, sorry, in Canada it wasn't a con.
Oh.
What is it? I couldn't hear.
Evusheld? Yeah, it was, can you want to explain what she was wondering what it was?
I couldn't understand, what was it that you had?
It's based, well, I mean, rather than giving you a vaccine and your body does all the work to create the immunization, they inject you with it. 2 shots in your butt.
What is it?
It's called Evusheld. It's not, I don't even think it's any value in now with all with the way that COVID-19 has progressed to different variants.
You know, there's concern you might not respond to the vaccine, but I might tell you still get the vaccine.
And I think the one thing he said about, because with all, and again, I've had TTP for 6 times over the last 11 years or something like that. So I see the doctor all the time, but I don't see my regular doctor. And that, I should see my regular doctor, right? But you go to the hospital all the time, getting blood taken all the time, constantly having this thing, and all of a sudden you get it again, so you're just peppered with that, and it is a good point. Don't let the rest of it drop, because...
Exactly, yeah. So, and I think
and it's easy to let it drop, because I see a doctor all the time.
Yes.
Right?
This is the exact discussion we had on earlier with just the physicians talking about how to encourage patients who do see a doctor or a hematologist all the time. How do you get them to go to a primary care physician? What do you do to encourage it? Because it is something, you know, obviously they recommend, but it's funny you mentioned that.
Yeah, but sometimes one will sick of going to practitioners. No offense to practitioners, it's just annoying.
Oh no, to their face is better. Very sick.
Not against you. Yeah.
But I think for TTP, we are now moving from TTP being an acute disease to a chronic disease. we are seeing most of the patients with TTP live a normal life. There are very few patients who die from TTP, I guess, like they did before.
When you say live a normal life though, are you taking into account?
Lifespan.
Lifespan.
Okay, that's not a normal life.
Sorry.
I wouldn't call that normal
Yeah.
life.
I think like in terms of mortality, we have made, I guess, good progress in terms of how many people were dying from TTP versus how many people are surviving TTP. So we deal with all these chronic problems now. So and more of cardiovascular prevention. So we don't know how to prevent that acute TTP or I guess like we don't have, other than monitoring ADMTS13, there is probably not much we know about how to prevent that acute TTP from happening again. But we can do that lifestyle modifications Dr. Cataland was mentioning to prevent that cardiovascular disease from happening. So better control of hypertension, diet, lifestyle modifications, checking your cholesterol and those kind of things.
There's no point in keeping you from relapsing if you're just gonna, develop a heart attack or some other issue. And then just to be blunt about it, right?
Yeah.
I try to do that.
Yeah, and I guess like when you go to a specialist, I think I admit that maybe I don't do a good job in screening patients for hypertension and diabetes because I haven't done it for so many years. When you go to a specialist, we focus so much on, we are tunnel visioned as physicians, and the more specialized we are, the more narrower our focus becomes and we ignore everything else. And primary care physician in my mind is a person who connects the dots and like more like a coordinating person or a central person who knows everything that happens with a patient compared to a specialist who sees only their specialty and kind of ignores the rest of them. So I encourage most of my patients to go see a primary care even though they see me every 3 months or so.
So we've got, I think, one more question, and then we're going to take a 10-minute break for the next session of breakouts.
This goes along with the lifestyle change. I know with congenital, no alcohol. Do we know the mechanism that alcohol affects congenital, or is it just kind of one of those?
I don't think it's necessarily a drink, it's the 12 of them. It's what goes along with intoxication, dehydration, and stress. I think that may be the bigger issue. But I don't think we know.
No, I'm unaware of like, if someone with immune or congenital TTP who's in remission and they want to kick back and they want to have a beer while watching the game, I would be hard pressed to think of a reason why they could not. I think our challenge is that, as hematologists, we have patients who are on blood thinners. Back in my day, you had a patient who was on a blood thinner that had lots of drug diet interactions, and alcohol really fouled up that thing. And when you have patients who are at risk for bleeding and they're also drinking, you do see people who do some knuckleheaded stuff. And those aren't the words that are in my head, but and so since you can't prescribe common sense, you have to say no. It's just a safer bet all around. I don't have to worry about someone getting, if they get drunk and fall out of a tree when their platelets are 5. Well, then Dr. Metjian never told me I couldn't do a 5th of whiskey every night. Right? I got we have to remind people, hey, smoking is bad, right?
And we can't recommend binge drinking.
Yeah.
It's just doesn't go well for anybody, whether you have congenital TTP or not. But I mean, that's really the issue with it. It's the congenital patients, and it's it's reported. I've heard it from patients, and these are college kids primarily. We see it. So this is not the guy or gal having 2 beers or 2 glasses of wine watching a tennis match. I think this is professional drinking going on. Average 18 to 21-year-old.
Yeah, but I mean, if I've had a patient with immune or congenital TTP, they're in remission, and they had a beer watching the game.
You take a beer, yeah. Got 12 of them?
Yeah. Right.
Speaking of drinking, get a coffee, get some soda, get some water, hydrate.